Welcome to the next talk. Today we're going to be focusing on musculoskeletal, orthopaedic radiology and presentations of lower limb injuries. So what are the learning outcomes? Well, we're going to look at bony anatomy on plain film radiographs and then go through some lower limb orthopaedic presentations and cases at the hip, knee and ankle joint, and how we're going to focus on management of these injuries, particularly in the emergency setting. So let's start with the hip. This is a normal AP anterior-posterior plain film radiograph of the pelvis, showing both hips as well. Now, key things to note when looking at this are we want to ensure this is the correct patient, the correct imaging, the correct date and time, and then the technical quality. In terms of an adequate technical film, we need to ensure that we can see both hips, we can see both proximal femurs, which we can in this case, we can see the entire pelvis, and the lower lumbar spine as well, all of which are visible. So this is an adequate film. Some of the key things that we can notice on this include the femoral head over here and the acetabulum over here with joint space between the two on both sides. We can see the femoral neck over here and then the greater trochanter here, a site for insertion of multiple muscles. The lesser trochanter is less visible over here, and then the proximal femoral diaphysis or shaft. We can see the superior pubic ramus over here, inferior pubic rami over here, the obturator foramen over here, and over here. We can see the pelvic ring as well, made up of the pubic rami anteriorly, and then posteriorly we can see laterally there's the ilium, and then there's the sacrum at the back over here with the sacroiliac joints over here as well, making up the pelvic ring. So there are multiple rings that we can look for as discussed over here. It's also important to be able to see the lower part of the lumbar spine, as it can give an indication as to any lumbar pathologies such as arthritis, which can sometimes manifest as pain in and around the hip. So after we've done that, we're going to focus in on looking at the hip itself. As we can see, we talked about the ilium over here, the acetabulum, the femoral head over here, the femoral neck as before, and the lesser trochanter, which is less visible. And the lesser trochanter can give an indication of how rotated the film is. Sometimes patients who present with pathology and fractures may come with a rotated limb, and judging that on a plain film radiograph can be done by the lesser trochanter. Now, the more of the lesser trochanter we can see, the more externally rotated the lower limb is. The less of it we can see, the more internally rotated the film is. Ideally, you should be able to see less than 5 mils of the lesser trochanter. So let's have a look at a case. We have an 85-year-old female who has dementia, who had a fall in her care home. It was an unwitnessed fall, and you take a full history as you can from her, but it's difficult due to her dementia. Therefore, you take a collateral history, and you find out she's not been mobile since her fall, and she's agitated. Now, it's really important to take a thorough history in these patients to find out some key information. This includes her mobility status, whether she's walking with a stick, a frame, any mobility aids, wheelchair bound before she had her fall, how her cognition is, and this is crucial because if an operation is to be done, then we need cooperation for rehabilitation. This may or may not be possible. In a patient with dementia, it's important to assess them as it can be mild or severe, and this can also impact. The third thing is to find out whether they are medically fit or whether they have multiple comorbidities, which again may make them more frail and put them at a higher risk of having any further procedures done. Once you find out all of these things, you try and investigate and examine the patient. An examination is difficult, but you're able to find out she's unable to flex or rotate at her hip. She's on multiple medications as listed over there as well. So let's move on to the obvious investigation, which is a pelvic radiograph. But it's important to notice that in these kind of patients who are elderly and frail, even having low energy injuries, they may sustain more than one injury. such as bleeds in the head, especially as a lot of these patients may be on anticoagulation medication, and therefore other injuries should also be screened for, and appropriate investigation should be done if required. So, for example, a CT head for patients who are presenting with a decreased GCS after having a fall, especially if they're on anticoagulation. But let's assume that that's all well, and it's just her hip that we're concerned about. As we can see, this is an AP pelvic radiograph. Now let's assume this is the correct patient, the correct date, the correct X-ray, and that we're happy with the technical quality, which we are of this film. As we can see, the entire pelvis, the proximal femora, and the lumbar spine as well, the lower aspect of. The main abnormality is a right neck of femur fracture. Now, let's have a look and see how we identified that. If we look at the normal left-hand side, we can see we look for a line known as Shenton's line. This follows the inferior aspect of the superior pubic ramus along to the medial aspect of the femoral neck, and appears to be a nice smooth curve or line. On the right-hand side, if we follow that line, we can see that it gets disrupted here and then continues up here, and that disruption is due to the neck of femur fracture. So, looking at that in more detail, this is a clearer depiction of what a normal Shenton's line would look like. But now we've identified that this patient has a neck of femur fracture, we now need to characterize this fracture and think about what else we would see on examination to confirm our findings. In terms of classifying the fracture, we can broadly classify neck of femur fractures into intra or extracapsular. This depends on a knowledge of where the capsule inserts as to whether the fracture is intra or extra. So let's have a look at that in a bit more detail. The hip capsule is a structure that runs from the rim of the acetabulum and inserts anteriorly at the base of the neck of femur, as depicted here. Posteriorly, it inserts proximally along the femoral neck, and so forms a circle around the femoral neck. The relevance of this is crucial, as the blood supply to the femoral head travels underneath the capsule and runs up the femoral neck to supply the femoral head, known as a retrograde blood supply. Therefore, any damage or any injury to the femoral neck may compromise the blood vessels coming from distal to proximal reaching the femoral head, and therefore may cause a vascular necrosis of the femoral head. For those fractures that are extracapsular, such as those denoted by the intertrochanteric fracture or subtrochanteric, the blood supply is still able to reach and run deep to the capsule without being disrupted, and therefore the femoral head is not at risk of a vascular necrosis. Therefore, intracapsular fractures have a risk of a vascular necrosis, whereas extracapsular fractures don't. And this is depicted clearly on the right-hand side with the capsule drawn in blue, and therefore we can see that subcapital fractures and transcervical fractures are intracapsular fractures, and therefore place the head of the femur at risk of a vascular necrosis. Intertrochanteric and subtrochanteric fractures are extracapsular fractures, and basicervical are on the boundary of being intra or extracapsular. So why is this important? As we can see, the red line shows a subcapital fracture and an orange shows a transcervical fracture, both of which we said are intracapsular. And you can see on the right hand side the blood supply forming a ring around the base of the neck of femur and then running underneath the capsule. And so these subcapital and transcervical fractures are going to place these at risk. So, having had a look at this fracture again, how would we classify it? Well, the capsule inserts along the intertrochanteric line here, and therefore this fracture is most certainly intracapsular. Classifying it further than that, we could see it looks like a subcapital fracture as it's just underneath the head of the femur. So this is an intracapsular fracture, or a subcapital, which by definition is intracapsular. So what might we see when we're examining this patient? We tend to see in patients with neck of femur fractures what we call a shortened and externally rotated limb. Let's have a look at why we get both of those things. As the neck of femur breaks, the muscles that cross the neck of the femur will shorten and contract, and this will cause shortening of the limb. Now, the direction of travel of the muscles crossing the neck of the femur such as adductors, hamstrings, and some quadriceps muscles, will determine the rotational deformity. And in this case, it's an external rotation that we see. Now, for most neck and femur fractures, we can see them clearly on plain film radiograph, and therefore we don't need to get any further imaging. However, if we're ever unsure or on x-rays and the patient still has symptoms and pain around the hip, then the most safe way to determine whether they have a neck and femur fracture would be to perform an MRI as according to the guidelines. Or practically in most hospitals, a CT is easier to obtain, and this can also be done. This will show definitely whether there is a neck and femur fracture or not, and therefore if there isn't, the patient can be mobilized, assuming there's no other injuries, and given soft tissue injury advice. If there is a neck and femur fracture, this needs to be treated as any other neck and femur fracture would. So how can we treat neck and femur fractures? Well, here are two options. Neck and femur fractures can broadly be treated with a fixation procedure or a replacement procedure. A fixation procedure involves the use of metalwork to fix across the fracture site to allow the fracture to heal. A replacement procedure, of which there are a couple of options, are shown in the images over here. And this involves replacing the patient's head of their femur and neck with a replacement implant. So in which cases would we do a fixation versus a replacement? This is where the blood supply and knowledge of whether the fracture is intracapsular and extracapsular is crucial. As we said, an intracapsular fracture places the head of the femur at risk of vascular necrosis, and therefore a replacement procedure needs to be done. As if we fix this, there would be a chance that the head of the femur would then undergo vascular necrosis, causing further pain and the potential need for another operation for the patient. If, however, the fracture is extracapsular, we can fix this, as we're not concerned about the viability of the head of the femur, as the blood supply has not been compromised. So, for our patient that we saw in the emergency department with an intracapsular neck and femur fracture, we need to do a replacement procedure. And here are two options. On the left-hand side, over here, you can see a HEMIARTHROPLASTY, or a half hip replacement procedure. On the right-hand side, we can see a total hip replacement. Now, what's the difference and how are we going to decide which one we do? The difference, as you can see, is that the hemiarthroplasty has a much bigger femoral head, and we don't touch the acetabular aspect of the pelvis. On the right-hand side, over here, we can see that this is a full or a total hip replacement, and we see that we have replaced the acetabulum, so we put an acetabulum component or cup in, as well as the femoral component, with the head being a lot smaller. Generally speaking, hemiarthroplasties are more suitable for elderly, frail population patients who need a stable, solid hip that they can mobilize on, but they do not have high functional demands. A total hip replacement is more appropriate for those patients who have a higher functional demand. The reason being that a total hip replacement has a metal surface on a acetabular cup which is made of polyethylene, and this gives better wear properties over a period of time. So more active patients, this will last longer in. However, there's a smaller head of the femur as compared to a hemiarthroplasty, and the trade-off is that this will be therefore less inherently stable and therefore more likely to dislocate than a hemiarthroplasty would. So for a frail elderly patient, we want to do one operation that's going to give them a stable hip that they can use. For a high functioning patient, we want to have those same goals, but we want to give them a hip that's going to be able to cope with the more functional nature that they have, and a total hip replacement would be worth that. So let's have a look at this other x-ray now. So as we can see, this is an AP pelvic radiograph. However, this is not an adequate one, as we can't see the top of the pelvis, and we certainly can't see the lower lumbar spine. Assuming this is the correct patient, let's have a look at what we can see. On the right hand side, we can see the femoral head, neck, greater trochanter, lesser trochanter, and shaft. And Shenton's line is nicely maintained there. So there doesn't appear to be any abnormalities there. Looking on the left-hand side, we can see again the head, neck, shaft, and at first glance, all appears to be fairly normal. But if we look more closely and trace Shenton's line, actually there's disruption around here. It doesn't look as smooth as the other side. And over here, there's disruption in the cortex. Looking closely, there's a small undisplaced fracture over there. So this is again a neck of femur fracture, but much more difficult to pick up than the last one. Again, this is intracapsular, as a capsule inserts over here. So what are our treatment options? We can treat it with a replacement procedure or with a fixation procedure. In this case, we've gone for a fixation procedure with screws. Now, I know that I stated earlier that fixation procedure is not appropriate for intracapsular fractures. But in this case, as it's undisplaced, this has been attempted. Now, some people may perform a replacement procedure rather than a fixation procedure. What are the benefits and downsides? Well, in a fixation procedure, there's still a risk of avascular necrosis as it's an intracapsular fracture, and therefore we'd have to monitor this patient. But it would hopefully be unlikely, as a fracture is not displaced. In a replacement procedure, we wouldn't have to worry about that. So what's the downside of doing a replacement procedure in the first place? Well, in a young patient, we want to try and maintain their femoral head for as long as possible before replacing, as unfortunately no replacements are ever as good as a patient's own femoral head. And replacements have a lifetime that they last for from 20 to 25 years. And therefore, we want to try and maintain this person's femoral head if possible, accepting that they may undergo avascular necrosis, but if they don't, they will maintain their own femoral head. If they do, then they may need further operations. Taking that same risk in an elderly or frail patient does not make sense, as we want to do one operation that will give them a stable hip, and we don't want to have the risk of doing another operation. And therefore the age of the patient and the functional demands may alter the operation you do. But in this case, we use cannulated hip screws. It's important to note that the aim of neck of femur surgery is to give the patient a stable hip that they can mobilize on straight away. And therefore, we would not place restrictions after doing a hemiarthroplasty or total hip replacement or a fixation procedure unless we are concerned about avascular necrosis. So let's have a look at this. Now, very clearly, we can see that there's a left-sided neck of femur fracture. But as we can see now, it's between the intertrochanteric line. It's at the intertrochanteric line. This is known as a intertrochanteric, or more accurately, a pertrochanteric fracture. Therefore, this is an extracapsular fracture, as this has occurred at the level of, or slightly more distal to, the insertion of the capsule. Therefore, in our options of fixation or replacement, we're not worried about the blood supply to the femoral head, and therefore a fixation procedure would be appropriate. They can come in many varieties. And as seen over here, the most common one of these is a dynamic hip screw procedure, which essentially kebabs the two ends of the broken bone together after it being reduced and allows the bones to compress at the fracture site when the patient puts weight on it to allow better healing. Again, the patient can walk on this as soon as they are able to after the operation. So now we've touched on neck of femur fractures, let's have a look at other hip presentations. This time we have a young 28-year-old male presented to the emergency department after a road traffic accident with an internally rotated and shortened right hip. He's complaining of severe pain in the hip and he's unable to move the right hip. So what's our first priority? Well, with a high energy injury, we'd have to default back to doing our ATLS, Advanced Trauma Life Support Resuscitation, ensuring that there are no life-threatening injuries that we're missing before moving on to any further orthopaedic injuries. So assuming that that's all fine, and for a detailed description of that, have a look at my trauma assessment video. We then move on to his injury. Now we're told he's got an internally rotated shortened hip. Now a shortened hip suggests that there's a fracture at some point, or that there's a dislocation causing the shortening. Internal rotation is almost never seen with neck of femur fractures. Bearing in mind his mechanism of injury, we'd want to take a history from him once he's stabilised and had his other injuries attended to, and then examine his hip with a neurovascular lower limb assessment. So we've treated him as per the ATLS guidelines, as described in more detail over here. And after that, we move on to doing a pelvis X-ray. He may have already had a CT scan as part of his trauma scan investigations, but if not, we need to form some sort of imaging. And as we can see over here, it shows a left-sided native hip dislocation, as the hip here should be contained within the acetabulum. Now, this may or may not be associated with a fracture, but what's clear is that there's a dislocation. Thinking about our neurovascular structures, we know that sciatic nerve runs posterior to the hip, and we therefore have to test this judiciously and document this before doing anything to this hip. But it's clear that this hip needs to be reduced one way or the other. And the way to reduce this would be to do this either in the emergency department, but more appropriately should be done in the operating theatre with a CT scan afterwards as well. Now, if there's a fracture of part of the acetabulum, it may be that reducing this under sedation will cause the hip then to come back out due to the fracture. But it's important to reduce the hip and then obtain a CT to see if there are any loose bodies in the joint or any fracture fragments that can be seen. And this needs to be then managed by a specialist in a specialist centre. On to the knee. Let's have a look at normal knee X-ray. As we can see here, the normal knee X-ray is made up of the distal femur over here, the proximal tibia over here, and the proximal fibula over here. On the lateral view, we can see the patella anteriorly, and for a good lateral, we should have overlap of the medial and lateral condyles. Not bad in this case, but it's not perfect overlap. As you can see, this is one of the condyles here, and this is the other condyle over here. So that's a normal knee X-ray. Let's have a look at a case now. We have a 65-year-old woman who presents with an 8-year history of progressive bilateral knee pain, which is worse on exertion. She's been on regular paracetamol and codeine, which has gradually stopped working over the last 6 months. Observations are stable, but she has a reduced range of motion as well as cracktus in the left knee on examination. To get X-rays of the knee. And it's important in this case, when we're not querying a history of trauma, we need to get a weight-bearing X-ray, as that shows the real-life scenario when the patient is mobilizing. Getting X-rays which are not weight-bearing can sometimes fool us, and we may not see the true extent of any pathology, especially arthritis. So looking at her knee, what can we see? Well, we see the same distal femur and the proximal tibia. And if we look at the joint spaces, we see on the lateral joint spaces here are well preserved, as there's a gap between the distal femur and the proximal tibia. In real life, that would be filled with articular cartilage, allowing frictionless movement. If we trace that medially, however, we can see that there's much less of a joint space and that the bone is essentially rubbing on the bone here, a medial femoral condyle with a medial tibial condyle. Therefore, there's reduced joint space on the medial compartment on the anterior-posterior view. Trying to look at the lateral view, we can see that this is certainly not an appropriate lateral film, as this is one of the condyles over here, and this is the second condyle here. So we have an oblique film, really, which is not appropriate to assess the patellofemoral joint. But we'd be looking for a reduced joint space at that patellofemoral joint, which is the third part of the knee, along with the medial and the lateral compartments. What we can say, however, is that this is arthritis of at least the medial compartment, some arthritis of the lateral compartment, and arthritis potentially of the patellofemoral compartment. So what do we look for when we look for arthritis on knee X-rays? Well, the key radiographic features of arthritis can be memorized with the mnemonic LOSS. L refers to the loss of the joint space, as pointed out in the previous film, and that can also be seen over here, especially when compared to the other compartment or the lateral compartment. O refers to osteophytes. This is excessive bone formation that can happen, and on the X-ray gives that appearance of loss of smoothness of the outline of the bones making up the knee. As we can see over here, there's this ragged edge over here, a loss of smoothness here, which is an osteophyte. S stands for subchondral sclerosis, and sclerosis is essentially a reaction of bone rubbing on bone, which is for the body to try and increase its density to cope with this stress. Subchondral sclerosis is seen as whiteness just underneath the joint line, seen over here, and more particularly over here, which looks whiter than the surrounding bone. And fourth is subchondral cysts. What happens in the pathology of osteoarthritis, which is a wear and tear pathology, is that once the articular cartilage has been worn away, we have bone rubbing on bone, and this can cause fissuring or cracking of the articular bone. This therefore allows fluid from the synovial space to propagate into the bone and can form little cysts here just underneath the joint line, which can be seen as darker circles or patches. In this case, it's difficult to see any cysts, but there may be small ones visible. So what are the options when dealing with people with knee arthritis? Well, as ever, with any arthritis, we can treat this with non-operative versus operative measures, and we generally start non-operatively. Non-operative measures include activity modification, reduced weight, so weight loss and lifestyle modifications. As we can imagine, reduced weight will put reduced force and load through this joint, and therefore reduce rubbing or arthritis. Other options include physiotherapy, as this strengthens the quadriceps and strengthens the muscles and the guide ropes around the knee. Other options include steroid injections. These can be done in the GP surgery or the outpatient clinic and are placed intra-articularly. Now, for people who have osteoarthritic pathology, it reliably tends to improve their pain for a certain period of time, which can last from days to months. However, reliably the pain does come back, and it is not a permanent solution. But it can be useful as a therapeutic, but also as a diagnostic measure, just to see how much of the patient's pain is coming from the intra-articular space due to arthritis. Some patients may have back-to-back steroid injections every few months, but eventually it gets to a point where if they're functionally struggling, not able to do their daily activities or daily work, and they have the radiographic changes that show that arthritis is the cause of this, then a total knee replacement may be the only appropriate option. As we can see over here, this is a total knee replacement. We replace the tibial plateau aspect, we replace the distal femoral aspect, and what appears to be a space in the middle is filled with a polyethylene to simulate the articular cartilage. We can see that we use this fluffiness around the components here, which is cement, both on the tibia and the femoral aspects. A knee replacement is a big undertaking to have, which requires physiotherapy afterwards. However, for people with severe arthritis, it can offer them the pain relief and the mobility to allow them to function at a good level again. Let's move on to the ankle. Let's take a case to begin with. We have a 52-year-old male who falls down the stairs and twists his ankle a week ago. It's painful and it's swollen, and he's unable to bear 3 steps. He has a past medical history of COPD, previous cardiovascular accident or stroke, cholesterol, severe type 2 diabetes, poorly controlled hypertension. Unless you're seeing him in the emergency department and taking a history, the first question is, does he need an X-ray after having examined him and finding out his neurovascular intact? Well, to help you decide, we can look at the OTTAWA rules. This states that if there's any bony tenderness along the distal 6 centimeters of the tibia or the fibula, or bony tenderness at the tip of the malleoli, or unable to walk 4 steps, then the patient warrants having an X-ray of the ankle. In practice, however, most patients will get an X-ray when they present like this. regardless of whether we meet these rules or not. So next question is, think about why this patient came only a week later. It may be that the patient tried to manage this by themselves at home, thinking that it was a sprain or that it may improve. Or it may be partly to do with the patient's past medical history. As we know, the patient is diabetic, and this can cause neuropathy in severe cases, which can mean that patients are more likely to have lower limb injuries as they don't have the protective mechanisms of being able to feel the pain, and therefore this can cause injuries to present late. Let's have a look at the normal ankle x-ray to begin with. As we can see, unlike most other joints, we look for three views when it comes to ankles. The AP and the lateral, as we would for any joint, and also a mortise view. The mortise view is taken with the ankle in 15 to 20 degrees of internal rotation and focuses on looking at the ankle mortise. This is formed by the distal tibia and fibula. This shows the mortise clearly, whereas the AP view shows the mortise with some overlap. Ankle injuries depend on the distal tibio-fibula joint, also known as the syndesmosis. This is a complex of several ligaments that hold the tibia next to the fibula. And you can imagine if these are injured or damaged, then the tibia can start distracting from the fibula, and this will cause the ankle to be unstable. And therefore, in all of our ankle x-rays or fractures, we need to assess whether the syndesmosis is stable. A stable or intact syndesmosis means that the ankle is stable. An unstable or syndesmosis which is compromised will mean an unstable ankle, and therefore may need an operation. And this is the basis of the Weber classification. The Weber classification looks at fibular fractures only relative to the syndesmosis. As we can see, it's split into A, B, and C. A Weber A fracture is at distal to the syndesmosis. So the syndesmosis would be where my arrow is now, and Weber A fracture is distal to that. As you can imagine, when the patient puts weight on their ankle, the syndesmosis is still intact, so the ankle is still stable and the tibia and fibula will not distract. Therefore, Weber A fractures are stable fractures and can be managed without an operation with a boot, or the patient can walk in comfortable padded shoes. A Weber B fracture is at the level of the syndesmosis. Now, these can be unstable or unstable. And to find out whether they're stable or not, it can be tricky when taking the x-ray, as there may not be any obvious signs of distraction or compromise of the syndesmosis. In this case, give the patient a boot and ask them to weight bear as tolerated, and see them back in the fracture clinic in a week's time, where we obtain weight-bearing views to stress the tibio-fibular distal joint, or the syndesmosis. If at this point the patient has been able to weight bear and their views in 1 week time show that there's no obvious injury to the syndesmosis, then we can treat this as a Weber A fracture non-operatively in a boot. If, however, there's distraction of the tibio-fibular joint, or the patient is unable to weight bear even with pain relief a week later, it may be that the syndesmosis is compromised and may need an operation. And finally, Weber C fractures are above the syndesmosis, and therefore the direction of travel of energy has gone through the syndesmosis and exited more proximally, and it's likely that the syndesmosis has been affected, even if it's not obvious on x-rays, and therefore an operation tends to be the most appropriate management plan. So let's have a look at this x-ray. Well, we want to look at a lateral and a mortise view, but this is an AP ankle x-ray, assuming this is the correct patient, the correct x-ray, and the correct time and date for that x-ray. We can see that the mortise does not seem to be compromised. What we can see is a fracture of the distal fibula. This would be a Weber A fracture, as the syndesmosis is here and it is distal to the syndesmosis. We said the syndesmosis is not compromised, and therefore this can be treated non-operatively in a boot or nice padded trainers, and pain relief and ankle elevation when at home to reduce swelling. Let's have a look at this x-ray now. Again, this is an AP mortise view and lateral. As we can see, there's a fracture here which is at the level of the syndesmosis. There's 2 fracture lines. So this is a Weber B fracture, and we don't know if this is stable or not. So if we saw this in the emergency department, the correct management for this would be pain relief, elevation, a boot, and ask the patient to weight bear as tolerated, and to be seen in a week in the fracture clinic with further weight bearing views to stress the syndesmosis after a week once pain has reduced, to see whether there's any compromise of the syndesmosis. If the syndesmosis at 1 week has been compromised, we need to potentially perform an operation, and if it hasn't, it can be treated like a Weber A ankle fracture. That's to say, continuing with a boot and weight bearing as tolerated. And this is a Weber C fracture. We can see it's up over here. Now, to the first glance, this is an AP view, and we want to get a mortise view, but we can't see any obvious disruption of the syndesmosis, although there may be a greater distance between the medial malleolus and the talus than there would be on the other side. It may be subtle, however, if there is a disruption there. But because it's a Weber C fracture, we've got a high suspicion that the syndesmosis has been compromised. And we certainly want to get this patient ready for an operation, assuming that patient factors are fit with this. So what might we do? As shown over here, this is one example of how a Weber C ankle fracture may be fixed. As you can see, this fracture of the fibula has been fixed, and we've also put a screw and a tightrope, or a different type of syndesmosis fixation, across the syndesmosis to make sure that that's stable, even though we can't see any obvious injury of the syndesmosis. Now, it's important to know that when the patients have this surgery done, it's going to be in a boot initially and non-weight bearing to rest the wound, but after, depending on how stable the fixation is, the patient may be allowed to weight bear from 2 or even 6 weeks onwards. It's important to be aware that you may get x-rays like we see in B, where we can see there's something going on here at the distal tibiofibular joint. There seems to be a greater distance than we would otherwise expect. And therefore, we look for a fracture, as it must be associated with that, but we can't see it on the ankle x-ray. It's important to note that we need to look higher up for the fibular fracture, as it can be a very high fibular fracture closer to the knee joint than the ankle joint. And if we get x-rays of the proximal fibula, we'll see that there's a high Weber C ankle fracture. This is known as a MAISSONEUVE fracture and should be treated like a Weber C fracture with syndesmosis fixation, although it's not necessary to fix the proximal fibula, as this will heal by itself. What is important is to stabilize the syndesmosis with an operation. This shows that in more clear detail. Sometimes we can see more than one fracture of the ankle. In this case, we can see what we know as a bimalleolar ankle fracture. This is by definition unstable, and therefore the ideal management of this would be to have an open reduction internal fixation operation to fix this, depending on patient factors. This is an example of what we might do. We fix both sides, and then we test the syndesmosis in the operation. As you can see, the fibular part of this fracture was a Weber B ankle fracture, and therefore once we fix the fibula, we then want to test the syndesmosis. If the syndesmosis was stable in the operation, which this one was, we can leave the syndesmosis and don't need to fix it. If the syndesmosis in the operation has been stressed and it is still unstable after fixing the fibula, then we would need to put a long screw or some form of fixation across the syndesmosis, like we saw with the Weber C ankle fracture, to fix that syndesmosis. So if this Weber B ankle fracture had a Weber C component as a fibular fracture, we would then, by definition, be putting some sort of fixation across the syndesmosis because that syndesmosis would be unstable. So in summary, hip fractures are the most commonly operated fractures, and it's key to be able to take a good history, in particular focusing on the mechanism of the injury, cognition of the patient, the comorbidities, and the mobility status, being able to clearly classify the fracture, which will then help with management in terms of fixation versus replacement. Intracapsular fractures being treated with replacement procedures such as a hemiarthroplasty or a total hip replacement, and extracapsular fractures being treated with fixation procedure such as a dynamic hip screw. Knee x-rays should be weight bearing if we're looking for signs of osteoarthritis, and we can remember the four signs such as loss of joint space, osteophytes, subchondral cysts, and subchondral sclerosis. The treatment options are always non-operative versus non-operative, and they range from lifestyle modifications, steroid injections, physiotherapy, all the way up to having a total knee replacement. And finally, ankle fracture management depends on the stability of the syndesmosis, and it's important to be able to characterize this. If you're unable to do so, then always see the patient back in the fracture clinic to be able to test this. Weber A ankle fractures are treated without an operation. Weber B can be treated with or without an operation, depending on the stability of the syndesmosis. And Weber C are mostly treated with an operation. I hope that was useful. Please leave any messages for any other topics you'd like to teach, and I'll see you on the next video. Thank you very much.